So as I said, my name's Josh Goodwin. I'm the doctor at Regenexx Las Vegas. We try to have these webinars about once a month, and so we like to have this format for people to join and learn a little bit about what we do here at Regenexx Las Vegas. The webinar is about regenerative interventional orthopedics, which essentially we'll get into, but it's really a concept of trying to preserve tissue as opposed to remove it surgically when we can, utilizing injection-based therapies and injecting cells that can be used to improve healing, inflammation, help improve the health of orthopedic tissue. So that's kind of the goal. I do encourage questions. As I mentioned, there's those sections, the chat section or the question and answer section, which are available to write questions as they come up. This webinar is more of a general overview of what we do, as opposed to very specifics for each joint and all those kind of things. It is geared only to orthopedic conditions because that's what we focus on. But it's more of a general overview of kind of an idea of what we do, how we make decisions on what we do, and then some contact information at the end if there was more information you needed, or if somebody wanted to be seen in clinic for an evaluation to get more specific information on your condition. So just to get into a little bit more about who I am. So as I said, my name is Josh. I'm the doctor here at the Regenexx Clinic. I'm a medical doctor. I did my medical school training in New Mexico. That's where I grew up. I'm board certified in physical medicine and rehabilitation. So that's what I did my residency training in. Fellowship trained in sports medicine and interventional spine. I've been with Regenexx since 2015, and I took over this clinic in Las Vegas in 2018. So I've been with Regenexx a while, and that's a little bit about my background. So as I mentioned, we're really here to focus on orthopedic conditions and, problems that affect our muscle, tendons, bones, spine structures are very prevalent. If we look at younger patients versus older patients, you see it in all age groups, and we've treated people in their teens up to their 90s. So it can affect many people, and we all know people that have had issues with their orthopedic tissues. And it's pretty costly to take care of. Just looking at some of the dollar amounts, and again, we all know people that have had issues, and again, just trying to figure out what are better ways to treat these conditions, since they impact lots of people. They cost a lot of money to treat. They are some of the number one reasons why people miss work or can't do things they want to do. We all are relatively familiar with some of the more traditional treatment options, including medications, different types of injectable agents, such as cortisone-based medications, physical therapy or bracing, and in some cases, surgery, right? This is an example of a knee replacement. And so these, have been used for a long time, but we do have to understand kind of the risks and benefits of even some of these traditional treatment options, and why we need to add more tools to our tool belt to be able to treat patients and maybe get better outcomes with less risk compared to some of these. So if we look even at just anti-inflammatory medications, such as your ibuprofen, your Aleve, and other prescription based anti-inflammatories, while they can be helpful, they also come with risk, right? There's many people that die every year from the use of these medications. They increase the risk of heart failure, kidney dysfunction, stomach ulcers, For some people, they get increased blood pressure. And there's been some recent studies that shows that actually by suppressing inflammation long-term can actually lead to chronic pain. So not medications are such as these shouldn't be taken lightly. It's best when people don't have to be on them long-term. And so we need to find alternative options to help reduce pain so people don't feel like they need to be on these medications. Although there are kind of more natural anti-inflammatory supplements like turmeric and fish oils and these kind of things that can also be helpful. One I don't have a slide on is cortisone-based injections. While those are also just very strong anti-inflammatories, and people that have ever had them or needed them on a regular basis have encountered the situation where they were told they can only get these a few times a year. We know they only lasted a couple weeks, but you can't get them for another few months. And that's because cortisone is toxic to your orthopedic tissue, cartilage, tendon. It can affect your blood sugars, hormone levels, weight gain. People can get anxious on them, those kind of things. So it's not the healthiest thing to expose your tissues to, especially your joints and tendons. So, so we really want to find alternatives to that. There's studies showing that the more cortisone injections you get into, say, for your knee, for example, the faster you get to a knee replacement. So something to keep in mind for those types of injections. Speaking of knee replacements and different surgical interventions, these are all more invasive than injection-based procedures. So because of that, there's that increased exposure to complications and risks. And so if you look at knee replacements, for example, up to 16% of the patients have serious complications. Knee arthroscopy, 5%. Less than 40% of people return to full activity after a knee replacement. And knee pain is the most common complaint after a knee replacement, which is what they got it for in the first place. So you got to think about these things when making decisions. And if there's alternatives that may be able to help preserve the tissue, strengthen the tissue, keep it functional without amputating the knee, without removing meniscal tissue, or in other joints like the hips or shoulders, or fusing the spine, then we need to look into those to see how, if we're a candidate, which we're going to talk about. Now, we also published a paper, the Regenexx group, that looked at 2,300 patients and looked at the adverse event rate for that. And these are the injection-based procedures that we provide, with a 0.17% adverse event rate related to procedures. So extremely lower than the surgical alternatives. So who is Regenexx and what is Regenexx? And so basically Regenexx is really a group of physicians that started in Colorado that had a different mindset on how to treat orthopedic problems, and kind of shifted towards the traditional treatment with cortisone injections and burning nerves and destructive type procedures, to trying to rebuild tissue, joint preservation, providing a healthy chemical environment to rebalance the degenerative process. And started in 2005, and it's grown a lot since then. So there's all these clinics around the United States and around the world. We're the only clinic here in Nevada, at least at the moment. There may be one opening up in Reno, but at least here in the Las Vegas area. And we've always had kind of the viewpoint of starting with innovation in the lab, doing clinical research. We continue to track patients in a registry, and we use that information to help change and augment our treatment suggestions and decisions. And then research is published from all of this. And so this is kind of the process that has gone on since 2005 in treating patients. and has helped advance and evolve this area of medicine with orthopedic care. And as we mentioned, this is just kind of the evolution of medicine, trying to reduce the invasiveness of orthopedic treatment options. And so, as I mentioned in the beginning, these are needle-based procedures. We use healing factors and components of our bodies or other types of tissues or injectables that can be placed via injection-based procedures to help improve a healing response, rebalance the chemical homeostasis in our body that assists with improving the health of the tissue, which can lead to improvements in function and reduction in pain. Again, the goal is to preserve tissue and reduce that exposure to risk that comes with more invasive procedures. And so some of the things that we use are called orthobiologics. And so one thing we have to kind of set the foundation for is just reminding everybody that we are able to heal. And we know this, and we have seen this throughout our lives. We've cut ourselves, we've broken bones, some of us have had surgery, and you still have to heal from that. There's trauma that's created from surgery that has to heal, and your body has these natural mechanisms to respond to that, going from a fractured bone to a healed bone, a trauma to the skin or soft tissue, and having new skin and repair of that soft tissue injury. So we do have mechanisms by which we can do that. And basically, as time has gone on, we've identified some of these things that we could take advantage of that can help restore some of the balance that gets thrown out and kind of altered with conditions as we age, wear and tear, overuse, traumatic type injuries, and try to help promote a more healthy environment. And so there's things that can be taken from the blood, taken from the bone marrow, taken from adipose tissue that you can use from your own bodies and use them in areas that are having some trouble with healing, degeneration, overuse, inflammation, these kind of things. And so one of the cells that we use are called platelets. When you isolate and concentrate platelets, that's called Prp, platelet-rich plasma. And if we look at the components held within inside platelets, there's these different growth factors, and these are involved with the healing process. So we have growth factors that stimulate cell growth, new blood vessel repair, collagen production. Collagen makes up our tissue. And so it's in order to promote healing, you have to be able to promote the production of that. Growth factors, again, involved with blood vessel growth, tissue repair, cell growth, wound healing, etc. And so we can use the properties of platelets for conditions such as mild to moderate arthritis, tendonitis, bursitis, small partial tears. We use it a lot in spine conditions. And this can help promote that signal to help improve the health of the environment, help stimulate tissue, help improve blood vessel ingrowth, these kind of things. And then people can experience improvements in pain and function as a result of that. There's proteins called A2M that can be found and isolated from the bloodstream, strong anti-inflammatories, and can help reduce swelling and cartilage breakdown. So there's some studies looking at that, and that can be used as well. We tend to use it in people that have an arthritic condition, for example, in the knee, where it keeps swelling and you need to try to, again, restore that anti-inflammatory balance, because our bodies always want to maintain a balance of inflammation, which in short term is very helpful for healing, but in long term can be detrimental to the tissue and destructive. So we got to kind of reset that balance for healing to take place. And then there are cells found throughout our body called mesenchymal stem cells We harvest this from the bone marrow, so it's called bone marrow concentrate. Bone marrow concentrate contains mesenchymal stem cells, and these are the cells that are able to respond to injured environments. They help direct tissue repair. They, again, also help maintain that homeostasis that helps improve the environment for healing. And so you can think of it like a contractor at a construction site that can help direct things and help organize the repair process. When you assess these cells in the lab, so you're trying to grow these cells in the lab to assess characteristics, they can transform into different types of cells. So that kind of gives them that added benefit. And then there's self-renewing properties. And we tend to use these for more moderate to severe conditions, larger tears, or conditions that weren't as responsive to the platelet-based therapies. And these can be helpful for different conditions. And so when we look at kind of research over time and how it's evolved with using stem cells for orthopedic conditions, very minimal studies in the late 90s, and it has grown significantly since then. So it's important to know that there is research out there looking at some of these, even though we need more and more all the time. This is specifically for just bone marrow derived stem cell research out there that's been published. And then looking at studies published with PRP, so those platelets that are isolated from the blood, looking at different conditions. Now this slide shows that PRP has been compared in a randomized controlled fashion compared to other interventions that are available for people to treat their orthopedic problems. So for example, in the knee, you can get a gel injection. And then these studies compared PRP to gel injections, showing PRP was more beneficial than gel injections, exercise, medications, multiple injections, saline, steroid injections, and so on. So there is data out there, again, just for knee arthritis, PRP, and bone marrow derived cells, lots of studies out there. So it's important to keep that in the back of your mind. There is research, even though we always need more and more and more. We're always trying to improve that and pump out research when we can. So now understanding that traditionally people are given anti-inflammatories, pain medications, cortisone injections, or surgery, what are other tools that we can use? And that's where Regenexx has been around, and other doctors even outside Regenexx. This field of regenerative medicine has grown. But now we have to have a process of, well, now that we have these different tools in our tool belt, how do we decide who's a good candidate for these types of procedures? Like all medical procedures, there are successes and failures. Not everybody responds the same. Despite maybe having a very similar condition, success rates can vary. So you have to have a process by which you evaluate people, understand what's going on, what is their potential for success based on the available studies and data that we have. And then you have to have a way that you provide the right type of treatment for the right condition. And then how do you deliver that PRP or that bone marrow concentrate or the A2M to the right locations? And that's where you have to use image guidance to be able to precisely place these cells where they need to be. So as I mentioned, we only focus on orthopedic conditions, including the spine, for disc bulges, sciatica, irritated nerves, joint arthritis, shoulder arthritis, rotator cuff tears, labral issues. Same thing with the elbow, golfer and tennis elbow, arthritis, torn ligaments, hand and wrist arthritis, carpal tunnel, trigger finger, hip arthritis, labral tears, tendinopathy, or tendinitis around the hip, knee arthritis and meniscal tears, ACL tears, MCL tears. You have your quadricep, your patellar tendon, hamstring tendons. All these things can be treated with some of the procedures that we perform here. So the process of prediction involves having a consultation, understanding that we have a registry. We're one of at least the first and with the largest registry out there, tracking patient outcomes of people that we have directly treated. I think right now we're tracking about 40,000 patients that Regenexx as an organization has treated. And then obviously pumping out research and understanding what research is out there that gives us an idea of who can be helped and who can't, or what overall success rates are. And so at least for us in our clinic, the consultation process is about an hour long, sometimes more depending on how many problems one person might have. This is where we review medical history. We understand things that may impact procedures, such as, other medical conditions with heart, blood thinning medications, cancer, these kind of things we have to know about. We have to review the imaging. And that's a big part of it, is spending lots of time educating you on what's going on structurally. Why do you have this hip pain or this knee pain? Where do we think it's coming from? And does the imaging correlate with what your symptoms are? We have to do physical exam. And then we have a discussion on the options. Do we think physical therapy is what you need? Do we think you need surgery? Or do we think what we provide with PRP, bone marrow concentrate, A2M, these injection-based procedures, can these be helpful for helping preserve your tissue, reduce the pain, help you be more functional? And then we create a customized treatment plan. So it's very individualized for what your specific problem is. As I mentioned, we use our registry data to help kind of educate people on the chance for success. And this is found on the regenexx.com website and our website, where you can look at different conditions and assess different conditions and pain, joint pain, improvement, function, that kind of stuff. I think right now for at least knee, we have about a little over 11,000 patients being tracked. There is a list of the studies that's been published by Regenexx, and then some current clinical studies. We have some that they're all done at the medical headquarters in Colorado, but we do have some recruitment for some clinical studies as well. And so that whole process leads us into, is somebody a high responder, a moderate responder, or a low responder candidate? And this can change based on the joint that you're treating, what the imaging shows, what the physical exam shows. So there's no way to kind of generalize it, because it just depends on what's going on for your specific problem, and everybody might have a little slightly different issue. And so we have to take a lot of things into account. So when people ask, well, what's the success rate of procedures? Well, it depends. What kind of candidate is somebody? What's going on? What other mechanical problems do they have? What do we see on physical exam? So there's a lot of things that go into defining success and the chance for success. So once we make that decision, we have the consultation and we develop a treatment plan. We decide, okay, platelet-based therapy is good for you. A2M-based platelet therapy is good for you. Bone marrow concentrate-based therapy is good for you. We have to have a process by which we maximize the customization and our ability to deliver the right dose, the right concentration for the problem. If you had to get treated for a specific type of pneumonia or infection, not only do you have to have the right medication, you have to have the right dose. And so this is very important for outcome. And so we have a flexible lab platform that we can customize concentrations. We can make sure that we get high doses compared to what a lot of people use as an automated machine that just pumps out a one-size-fits-all approach. And so we have a custom lab where we can customize concentrations based on age, injury, location, tissue. We can make multiple different products in one setting. And so that's very useful for the unique things that we see with patients, right? they might have a bone and a joint and a muscle and a tendon and a nerve problem, and all of those different tissues might need something different. And so it's important to be able to have that ability to customize treatments. And then when you're going to deliver the injections, you have to be precise. These types of treatments need to be very precise to where the problem is. And so we have to use X-ray guidance, or we use ultrasound guidance depending on the problem. We use imaging to help understand structurally what's going on. So this is an MRI of the knee, a cross-section, kneecap, some bony injury into the kneecap, cartilage loss, which is osteoarthritis behind the kneecap, a little inflammation, needles injecting these areas. So important to when people get these procedures, to go to somebody that knows how to be precise and uses image guidance. Another example, injecting the shoulder with X-ray, an ultrasound example showing a needle, a 30 gauge needle, so a very skinny needle, injecting around the carpal tunnel nerve for carpal tunnel syndrome. So very useful for safety, for outcome, for targeting the tissue that you want to target in order to maximize the outcome improvement. And so this is kind of what I feel the Regenexx differences is. We have a process for prediction. Even though we don't know specifically what's going to happen with you, we've tracked patients, kept track of research, so we get a sense of, are people high, mid, or low responders. The processing, we're flexible. We have a lab that we can customize treatments, and then we precisely inject via image guidance to help improve and maximize the chance for success. And so just a kind of a brief summary of the procedure. So for, say, a blood-based procedure where we're doing platelets or A2M, this is just a one-day procedure where there's a blood draw processing, which takes an hour to 2, and then the re-injection all same day with image guidance. All these injections, because of the mechanism by how these cells kind of create a response, people can get a sense of stiffness and a little bit of swelling at the sites of the injection for about 48 hours. So you need to modify your activity. Some people need bracing, some people need physical therapy after. Some people will need more than one injection over time. The improvement happens over weeks to months as opposed to days, as your body has to go through the process of responding, recruitment, the regenerative process, the strengthening process, which takes time. And so you'll see improvement over time, and then that improvement can last over time. But some people do need more than one treatment. We follow up people every 6 weeks or so to make sure they're doing well, and then make more decisions based on their response. So again, it's not a one-size-fits-all. We don't just schedule people for a series of injections because we want to inject you 3 times. We basically create a plan, implement that plan, and then follow up and reassess. The bone marrow concentrate process, the bone marrow that contains the mesenchymal stem cells. For arthritic joints, we tend to do a 3-step process where we create a little inflammatory response, more of an acute healing response with prolotherapy. And then 2 days later is when we isolate the cells from the bone marrow, count the cells, verify viability, and inject all in the same day. And then about 4 to 7 days after that, we do inject PRP and platelet growth factors to help kind of fertilize that area. So a little bit different process for a complete, for more severe conditions where we're taking people through this 3-step process for utilizing the bone marrow concentrate. And not everybody needs the 3-step process. This depends on the problem. But those are some of the differences between those different procedures. And so, as I mentioned, there has been over the years lots of stem cell hype. Despite a lot of these things being called regenerative medicine, there are limitations in what structurally changes depending on what's wrong. So if you have a completely bone-on-bone joint, there is no study regardless of what type of cell was injected. That shows complete cartilage regrowth over an entire bone-on-bone joint. So something to keep in mind. Now, it doesn't mean you can't be helped in regards to pain and function and preservation of tissue and supporting the tissue if you have bone-on-bone. It just means that it's not going to grow a new joint as if you've never had degeneration. That just is not possible at this point in time. We do have to remember there is FDA compliance and regulation over these different procedures. And in order to be compliant, you have to do certain things and not do certain things to stay within compliance. We will not go through these regulations. It's beyond the scope of this talk. But a lot of what we see are kind of claims about umbilical cord blood or cells being the best thing. But none of these things are approved by FDA. Physicians have lost their license and been shut down by using these. There's link to some contaminated products in the past. We've checked a lot of these different products out there and have shown that, at least in the United States, none of these umbilical cord products or amniotic tissue products contain any live cells. They're all dead tissue. This is an example of an umbilical cord product that said it had 10 million stem cells and it has 0. None of them could grow. This is a middle-aged bone marrow, which readily grows your stem cells. And so when people say, well, I should get an umbilical cord product because they're young cells, well, the products in the US are dead. So you can get dead tissue or live functional tissue with platelets and growth factors and all these other things. So, outside the United States, there's less limitations on what you can do. So with those cells where you can actually purify stem cells from umbilical cord, that's just not allowed in the United States. There's also pretty limited studies, again, on the use of umbilical cord stem cells. And again, we could use these if we wanted to order them. Like, there's no barrier to get them. It's just that we haven't found the need. Plus, it's against FDA regulations. And if we want to stay in practice, we don't want to be doing things that are not legally allowed. And so at this point in time, we are still using your own cells because that has a long history. We've published safety studies amongst other people that have, and then we've been tracking patients since 2005. So that's kind of where we are with that. I do want to see if there's any questions, and then I'll go on to the next slide where we have contact information to Lauren in our patient education center, her email and phone number. If you had more questions and wanted to reach out, then she's a good resource. She can give you information about how to schedule an appointment, how to get your imaging to us for a review. Sometimes we'll review MRIs to see, is it worthwhile to come in for a consultation? That can be really helpful, just so you would have an understanding that there's some potential. And so we do that for people as well. So if anybody has any questions, again, in the Q&A section or the chat section, you can type them in there. I try to highlight some of the basics. As I mentioned, this is more of a general overview, not very specific to any specific joint or condition or severity. Again, success rates can vary based off what we see, right? There are some joints that are more responsive or less responsive than others. For example, like the hip joint doesn't do as well as, say, the knee joint or the shoulder. So we're a little more cautious at our recommendations in those specific joints. For most joints, age doesn't seem to play a role in outcome, except for maybe the hip joint. So people will ask about that. Does age seem to matter? We've checked the outcome data in people from their 30s to 90s for arthritic conditions, for say, for example, the knee or shoulder, and we haven't seen that age made that much of a factor. It made no factor in some of these. The success rates were pretty equivalent over the different age distributions, and so people asked about that a lot. A question about how responsive are PRPs for the nerves pressing in the spinal area. Again, it depends on maybe what's causing it and how bad is the pressure on the nerves. When people have a completely pinched, compressed nerve where there's just no space around the nerve because it's being completely pinched off, then it's hard to say that PRP is going to be successful in that situation. You have to have space to be able to get a needle and be able to inject. Having said that, we have treated pretty large disc herniations that are irritating nerves, some ligament thickening, these kind of things that can be targeted. So usually kind of mild to moderate herniations. We have treated some large herniations, but there has to be some space to be able to inject. So depending again on how much pressure there is or how much reduction in nerve space there is, that could affect the overall potential. So it gets down to just looking at, say, an MRI and understanding structurally what's going on. If you had a big bone spur completely obliterating the nerve space, then PRP is not going to be that helpful in that situation. But outside that, and as if there's some space, then we've had some good success with treating around nerves in the spine. But there's different factors that play into success there as well. But it definitely seems to be more effective than just doing, say, like a cortisone injection or something. And some people, there's no other questions in the chat, but some people will ask about risks. Really, the risks come from just the needle pokes. There's not much added risk from injecting, say, bone marrow-derived cells or PRP or A2M. It's more the fact that you have to deliver it with an injection. And so there's always a risk for bleeding, infection, nerve injury, irritation, a little bit of swelling, redness, those kind of things. So similar risks as if you were injecting cortisone or a gel injection in the knee or something, because it's the act of poking a needle through the skin that exposes you to any type of risk or complication. Some people also ask about just multiple joints. So say you have both knees or a back and a foot. With the bone marrow process, you can treat typically up to 2 locations, like 2 regions. With PRP, you can treat many more. You have more blood volume. For bone marrow, you have to reach kind of a dosing threshold in each area. So we're kind of limited by that since we're not allowed to grow out any stem cells in the United States. We can only isolate and concentrate them. So the FDA regulates what you can do with your own cells. You can isolate and concentrate them and inject them, but you can't expand and grow and culture. So something to keep in mind. Let me see, there was another question about an Achilles. So there's some Achilles pain. Do I need to bring an MRI? If you have an MRI, definitely send it in. If you don't have one, we can order it. The Achilles tendon, we can also probably get a good sense of what's going on with an ultrasound. So I have ultrasound in the clinic where we can do a diagnostic ultrasound to look at it. If we have all the information with that, we won't need an MRI. If it seemed like we weren't seeing what we need to see or it wasn't explaining your symptoms, then we could get an MRI. But if you have one, yeah, definitely you can bring it in or send it in for review. Okay, yeah, if you don't have one, we can just potentially look at it with ultrasound in the clinic in the new patient evaluation and see if we can see what's going on and why there's pain. So if you can just reach out to Lauren if you're ever interested in that, to kind of just get the assessment. We'd have to see what's going on to see what the options are, you know. And there's many different options for, say, Achilles tendonitis or partial tears or just irritation, those kind of things. Some of it's what we do, some of it's therapy, some of it's shockwave therapy, some of it's 10X, which is a different type of needle procedure. So there's a lot of things that can be done, just depends on what's going on. People don't need to go to an orthopedic. I mean, I'm fellowship trained in sports medicine. My background's physical medicine and rehab. We do a lot of stuff with orthopedic docs. If you wanted to go to an orthopedic to get their opinion first or to do a little workup, that's fine. But we can also look at it and kind of help guide what needs to be done next or what imaging needs to be ordered. We don't need referrals for people to come in here. So unless for whatever reason, the new patient consultations can go through insurance if we take your insurance. Most PRP and bone marrow procedures are not covered by insurance. Regenexx does have coverage through different employers through our corporate plan. So we have about, I think, close to 500 organizations that cover Regenexx, covering about 12 million lives. So there are some people that do get coverage for all of the procedures, but new patient consultations can be billed to insurance. So you don't need to go to an orthopedic doc first, but you can if you feel more comfortable with that, but we can look at it too. Any other questions? I'll just give it a yes. I could diagnose Achilles tendon issues. Like I said, we would do an exam. We would do an ultrasound during the consultation, which gives us feedback right away, so we could see what's going on. If we didn't see what's going on, then we can order an MRI if we needed it. So I can do all of that. In the future, we will have different webinars, again, for more specific conditions, like a low back webinar or a knee webinar or shoulder, those kind of things. Are you able to see the screen here? You can just call this number, or you can email Lauren at this here. This is her email. She's our patient coordinator and patient educator and scheduler, so she can help you there. And if you can't see that for whatever reason, it's 702-986-0921. That is our patient education call center, essentially. Well, I don't see a lot of other questions. I'll let you guys get back to your evening. Again, if there's more questions, email Lauren, call the number. You can reach out directly to our clinic. Like I said, you can get your information in. You can come in for a consultation just to get an idea for your specific condition. Trying to cover all different joints and success and limitations is really hard. We'd be here for a long time. So if you have more specific questions or want to be seen in the clinic, just reach out to Lauren. She can get you educated and on the schedule, and then we'll go from there. So I appreciate your guys' time. I'll go ahead and end the seminar there, and if you end up scheduling an appointment, we'll see you then.